Our next topic is preterm labor. Preemie babies, major concern. It used to be that intensive care nurseries took care of sick babies. Today, it is premature babies. Some of these babies are so tiny, they look like wet rats. So tiny. The smallest baby that I was involved with was Cora. She weighed 385 grams. 385 grams, and survived. She's done amazingly well. She was a surviving twin of a twin-twin transfusion. And here she is today. A miracle baby, to be sure. Here's our case. A 24-year-old woman, gravida 2, para 1, 28 weeks gestation by dates, comes to the birthing unit complaining of regular uterine contractions every 7 to 10 minutes. So she's preterm, at least by dates, is having contractions. She's a smoker with chronic hypertension. What do you think the size of her baby should be if she's a smoker? Smaller? Larger? About the same? Smaller, wouldn't you expect? No prenatal care, but the fundal height is 35 centimeters. What should be the fundal height at 28 weeks? 28 centimeters. Why is this fundal height higher in a woman who has chronic hypertension and a smoker? Her previous pregnancy ended with spontaneous vaginal delivery at 30 weeks gestation. So there she has a risk factor for preterm delivery, a previous baby that was preterm. When we think of fundal height larger than dates and preterm contractions, could she have twins? And that's a possibility. Let's look at preterm labor. The Institute of Medicine report says 1 in 8 babies are born prematurely. That's 500,000 babies a year with incredibly high costs. And their recommendation from the Institute of Medicine is we need to be more assertive in getting early ultrasounds to date the pregnancies so we're not delivering babies prematurely, and less aggressive infertility treatment so we don't have all these super multiples. This is looking at the preterm delivery rate from 1982 to 2002. And is it coming down? It's going up in spite of all the efforts that we make. Okay, this slide looks at where we're going to go here. We're going to try to define preterm labor, and there are 3 criteria: contractions, 3 and 30 minutes, weeks, 20 to 35 weeks, and evidence of cervical change. Once we've got the diagnosis down, we need to ask, are there reasons why we shouldn't stop labor? Contraindications, obstetrical, fetal, and maternal. The most common tocolytic agents that we use: magnesium sulfate, beta-adrenergic agonists such as ritodrine terbutaline, prostaglandin synthetase inhibitors such as indomethacin, and calcium channel blockers such as nifedipine. But remember, all of these can only be counted on to delay delivery for 48 hours. Is that helpful? Yes, it is, because we can give betamethasone to induce fetal lung surfactant, and we give that if she is less than 34 weeks. And we always want to assess with premature babies, is she group B strep positive, because we need to give IV Pen-G to prevent group B strep sepsis. If you're presented on the exam with a patient who has contractions, this is your differential diagnosis. Could she have uterine irritability? Could she have Braxton Hicks contractions? Could she have preterm contractions or preterm labor? And let's look at differentiating these. We already said that 10% of all deliveries occur before 37 weeks, and it is a main cause of neonatal deaths. And this is a major concern of the March of Dimes. Blacks are unduly represented in preterm births compared to whites, Native Americans, Asians, and Hispanics. Why is prematurity such an issue? And this slide shows the mortality rate by gestational age. 24 weeks, 80% will die. Just 2 weeks more, we cut that by half at 26 weeks. If we can prolong the pregnancy 2 weeks more, we cut it half again. And you can see we go from 80 to 40 to 20 to 10 to 5. major concern, prematurity. All right, preterm labor. What are the criteria for diagnosis? Number one, gestational age, between 20 and 36 weeks. If it's less than 20 weeks, we call that an abortion. If it's over 36 weeks, we call that functionally term. There must be contractions, at least 3 in 30 minutes. If there are no contractions, you can hardly have labor. Of course, the patient may not be aware of it. Probably the most significant criteria, however, is there must be either change in the cervical dilation or effacement on serial exams, or on a single exam, she should be 2 centimeters or more dilated. And the reason why we say she should be 2 centimeters or more, because many patients, particularly multiparous, are 1 to 2 centimeters for weeks. This is a patient who comes in, and this is her contraction pattern. She's having 7 contractions in 5 minutes. But what is the duration of her contractions? About 20 seconds. Low intensity, high frequency, uterine irritability, not to worry. Here's another contraction. There's only 1 contraction, and how long does it last? 1, 2, 3, 4 minutes. This is not the contractions of labor. This is Braxton Hicks contractions. Not to worry. Start as early as 14 weeks. Okay, the last 2 of our differential diagnoses were preterm contractions and preterm labor. How do we distinguish between those? This is preterm labor, 20 to 36 weeks, 3 contractions in 30 minutes. Cervix is dilated, either 2 centimeters or more, or is changing. Notice the difference between this one. Preterm contractions, 20 to 36 weeks, 3 contractions in 30 minutes, either dilated less than 2 centimeters on a single exam, or no cervical change. The distinction then is between cervix changing and dilated, or cervix not dilated and not changing. Many patients can have preterm contractions, but they may not be in preterm labor, and the difference is the cervical exam. Cervical change, no. Preterm contractions. Cervical change, yes. Preterm labor. Don't fix it if it ain't broken. If she's not changing her cervix, she's having preterm contractions, there is no need to treat. Risk factors for preterm birth. This would be a good board question. Multiple gestation, we said 50% of those babies will deliver before 36 weeks. If there is a uterine anomaly, septate uterus, didelphys uterus, 50% will deliver prematurely. Interestingly, 50% will deliver at term. If there is a previous preterm birth, 25% risk of preterm delivery. So these are significant risk factors. When you look at the factors responsible for preterm birth, probably the most significant one is infection, and that raises a real issue. Should you continue pregnancies that are infected? And if they have a subclinical infection, maybe we shouldn't be stopping them. There could be uterine ischemia, uterine overdistension, such as with twins, cervical pathology, such as a cervicitis, abnormal allograft rejection, allergies, endocrine. This is not a simple mechanism. This is a multifaceted pathophysiology. Now, we used to say that heart disease and cardiovascular disease was related to cholesterol. Nowadays, we realize that there is a significant inflammatory component, and one of the ways of assessing risk factor for cardiovascular disease is C-reactive protein. The same thing is true with preterm labor. There is evidence that there is a significant inflammatory response. Women who have periodontal disease have a higher risk of preterm birth. Women who have bacterial vaginosis have a higher risk of preterm birth. Women who have trichomoniasis have a higher risk of preterm birth. So infection may very well be an underlying pathophysiology of many preterm births. Now, what is interesting about this article is that treating a patient with metronidazole who has trichomoniasis does not reduce preterm delivery. And the suggestion here is that the metronidazole causes destruction of the trichomonads, which release then cytokines and interleukins, which stimulate more contractions. So just because a patient has an increased risk with trichomoniasis, treatment may not necessarily reduce it. With vaginal ultrasound, we can assess the cervical length, and cervical length seems to have a significant predicting value in preterm birth. The shorter the cervix, the higher the risk. The longer the cervix, the lower the risk. This looks at a long cervix, a short cervix, and what it shows is as the cervix gets shorter, the risk of preterm birth goes higher. So one way of assessing preterm birth is to look at ultrasound cervical length. Cervical length, particularly short cervix, may be a risk factor for ascending microbial invasion from the vagina coming up into the uterine cavity and causing an infection. This is a patient that I did an ultrasound on, and you can see she has a long cervix, 42 millimeters long. 1 week later, I repeated it, and what did we find? It's now 15 millimeters long. Look at the difference, from long to short. Clearly, this woman is at high risk for preterm birth. Symptoms of preterm labor. Many women may not feel strong uterine contractions. It may be lower abdominal pressure, it may be back pain, increasing vaginal discharge. So we need to educate patients who are at risk. What are the symptoms? I told you about this patient who had twins, who was 30-some weeks, didn't even know that she was having labor. She perceived it as back pain. We need to educate our patients. All right, we've made the diagnosis. She's between 20 and 36 weeks. She has 3 contractions in 30 minutes or more, and either evidence of cervical change or she's dilated 2 centimeters or more. Now what do we do? Maybe there are reasons we shouldn't stop labor, what we call contraindications, conditions under which stopping labor is either dangerous to the mother or baby or futile. Futile means it doesn't make any difference. Obstetrical contraindications, severe abruption, ruptured membranes, chorioamnionitis. Fetal contraindications, lethal anomaly, anencephaly, renal agenesis, baby's already dead, fetal demise, fetal jeopardy, severe late decelerations, bradycardia. And maternal contraindications may be she's got eclampsia, severe preeclampsia, maybe she's 8 centimeters dilated. So if any of these are present, it would suggest let nature alone. Now, studies have been done looking at the number of women who meet the 3 criteria that we talked about. How many of them do not have a contraindication? In other words, how many are appropriate candidates for stopping labor? And if you take 100 patients who meet the criteria, only 10% are actually candidates to stop. Because most patients who are in true preterm labor have 1 or more of these contraindications. All right, we've made the diagnosis, we've ruled out contraindications. What agents will we use? And here are the most common agents used: magnesium sulfate, beta-adrenergic agonists such as ritodrine, terbutaline, calcium channel blockers, nifedipine, prostaglandin synthetase inhibitors such as indomethacin. Here are board questions. What are the significant side effects you should be aware of? Magnesium sulfate, respiratory depression. Put that someplace in your hard disk. Beta-adrenergic agonists, hyperglycemia, hypokalemia. Patient has gestational diabetes, managed by diet. You put her on these medications, and now she needs insulin. The hypokalemia, the potassium moves intracellularly. It's a temporary reversible effect. Calcium channel blockers, myocardial depression, hypotension. If a patient already has cardiac disease or low blood pressure, you better be concerned about using nifedipine. Prostaglandin synthetase inhibitors, two particular issues you need to be concerned with. One is oligohydramnios, decrease in amniotic fluid. This is because of decreased renal perfusion resulting in decreased amniotic fluid. Oligohydramnios. This is typically a reversible phenomenon. Intrauterine closure of the patent ductus arteriosus. The ductus needs to remain open in utero. This seems to be a gestational age-limited finding. It's unlikely less than 32 weeks, more likely after 32 weeks, so we will not use indomethacin after 32 weeks. All right, here are some great board questions. Preterm labor tocolysis, respiratory depression, muscle weakness. What is the agent? Magnesium. What's the treatment for magnesium overdose? Stop the mag, obviously, calcium gluconate. You knew that, right? Now you do. Many people suggest magnesium sulfate is no better than saline, placebo. And this was a recent article by a well-informed researcher suggesting maybe it's time to retire magnesium sulfate. We'll see what the future shows. Preterm labor tocolysis, tachycardia, hypotension, myocardial depression. What's the agent? Calcium channel blockers. Preterm labor tocolysis, hypokalemia, hyperglycemia. What's the agent? Beta agonist, ridodrine terbutaline. Preterm labor tocolysis, oligohydramnios, patent ductus arteriosus closure in utero. What's the agent? Indomethacin. Recent work has looked at prevention of preterm birth by injecting 17-alpha-hydroxyprogesterone caproate. Remember previously we talked about that one of the effects of progesterone is to stabilize the smooth muscle of the uterus. And very encouraging work has looked at injecting progesterone starting at 20 weeks and giving it weekly to lower the preterm delivery rate. We'll see whether this works out in larger trials, but it does look very promising. All right, what have we said? In review, preterm labor, criteria, contractions, 3 and 30 minutes, weeks, 20 to 35 weeks, and there must be evidence of either cervical dilation or change. Rule out contraindications. Once you've got the diagnosis and there are no contraindications, give your tocolytic agent, and remember, you're not going to delay delivery for weeks. The best you can expect is for 48 hours. In that 48 hours, we will give betamethasone. You need to give 2 doses. We give this if she's less than 34 weeks. Transfer the mom to a hospital that has an intensive care nursery. And remember, we'll do a vaginal culture. In the meantime, we'll put her on IV Pen G to prevent for group B strep sepsis. And that is the end of preterm labor.